Anaphylaxis. Key points. Anaphylaxis is a severe allergic reaction characterized by an acute onset of cardiovascular, e.g. hypertension, or respiratory, e.g. bronchospasm, symptoms. It may be associated with typical skin features, urticarial rash or erythema/flushing and angioedema, and/or persistent severe gastrointestinal symptoms. Treatment of anaphylaxis is intramuscular adrenaline 10 microgram/kg or 0.01 ml/kg of 1:1000, maximum 0.5 ml, into lateral thigh, which should be repeated after 5 minutes if the child is not improving. In children with possible anaphylaxis and known asthma, always give adrenaline first, then asthma medicines. Do not allow children with anaphylaxis to stand or walk. Background: most reactions occur within 30 minutes of exposure to a trigger but can occur up to 4 hours later. Causes of anaphylaxis in children include foods, peanut, tree nuts, cow milk, eggs, soy, shellfish, fish, wheat, bites/stings, bee, wasp, jackjumper ants, ticks. Medications: beta-lactams, NSAIDs. Other: exercise, idiopathic, rubber latex, bottle nipples, pacifiers, toys. Newer monoclonal antibody therapies may produce delayed anaphylactic reactions and rebound symptoms that occur more than 12 hours after the initial reaction. NB, a cause is not identified in 20% of cases. Assessment: identify risk factors for fatal anaphylaxis. Delay to administration of adrenaline or emergency response services. Poorly controlled asthma. Allergy to nuts, shellfish, drugs, and insect stings. Adolescence. Pre-existing cardiac and respiratory conditions. Anaphylaxis is a clinical diagnosis made in the setting of the acute onset of either criteria. Typical skin features: urticaria, flushing and/or angioedema, plus involvement of respiratory and/or cardiovascular system, and/or persistent severe gastrointestinal symptoms, especially after exposure to non-food allergens, e.g. insect sting, or hypotension, bronchospasm or upper airway obstruction where anaphylaxis is possible, even if typical skin features are not present. A detailed history of pre-hospital events is vital to confirm anaphylaxis and its associated trigger. Clinical features. System: respiratory, most common in children. Features of anaphylaxis: persistent cough, wheeze, stridor, hoarse voice, difficulty talking or change in character of cry, tongue swelling, chest pain or dyspnoea, subjective feeling of swelling, tightness, or tingling the throat or mouth. System: cardiovascular. Features of anaphylaxis: pale and floppy, infant. Palpitations, hypotension, pallor. Collapse with or without unconsciousness. Cardiac arrest. Palpitations, tachycardia, bradycardia. Respiratory system. Respiratory, most common in system. Neurological. Features of anaphylaxis: dizziness, altered consciousness, confusion, sudden behavior change. System: gastrointestinal. Features of anaphylaxis: nausea, vomiting, dysphagia, abdominal or pelvic pain, diarrhea. Dermatological: urticarial rash, erythema, flushing, tearing, angioedema, pruritus, skin, eyes, nose, throat, mouth. Management, investigations. Anaphylaxis is a clinical diagnosis. A serum tryptase has no role in acute management of anaphylaxis. It should only be ordered after consultation with a pediatric allergy specialist in special circumstances. Treatment: remove allergen if still present, e.g. insect stinger, food debris in mouth. Lay patient flat, do not allow the child to stand or walk. Fatality can occur within seconds if the child stands or sits suddenly. Treat the child in the supine position or lying on their side. If a vomiting child is sat upright, monitor for hypotension. Repeat intramuscular adrenaline 10 microgram/kg or 0.01 ml/kg of 1:1000, maximum 0.5 ml, into lateral thigh, which should be repeated after 5 minutes if the child is not improving. Do not use SC adrenaline, as absorption is less reliable than the IM route. Do not use 4-bolus adrenaline unless cardiac arrest is imminent. Use an adrenaline auto-injector if unable to calculate exact dose or to avoid delay, including in children and LT 1-year-old. The following doses of adrenaline may be used. Adrenaline doses. Age, years. And LT1. Weight, kg. And LT 7.5 kg. Volume of 1:1000. Adrenaline, 0.1 ml. Adrenaline auto-injectors. Not available. Age. And LT1, 2. 7.510. 0.1 ml. 0.15 mg device. Age, 2-3. Weight, 15. Volume of 0.15 ml. Adrenaline auto-injectors. 0.15 mg device. Age, 4-5. Weight, 18. Volume of 0.18 ml. Adrenaline auto-injectors. 0.15 mg. Age, 5-6. Weight, 20. Volume of 0.2 ml. Adrenaline auto 0.3 mg device. Age, years. 7-10. Weight, 30. Volume of 0.3 ml. Adrenaline auto-injectors. 0.3 mg device. Age, 10-12. Weight, kg. 40. Volume, 0. Adrenaline auto, 0.3 mg device. Intramuscular, age, years. And GT12, weight, kg. And GT50. Volume of, 0.5 ml. Adrenaline auto-injectors. 0.3 mg or 0.5 mg device. Example auto-injectors. Brand name, EpiPen JR registered. Indications, children and LT 5 years old and 7.5. 20 kg. Image, green. Brand name, EpiPen registered. Indications, children and GT 5 years or and GT 20 kg. Image, yellow. Anaphylaxis registered. Indications, children and LT 5 years old and 7.5. 20 kg, 150 mcg. Children and GT 20 kg, 300 mcg. Children and GT 50 kg, 500 mcg. Image, white. Give oxygen. If not improving, give a second dose of adrenaline. Consult senior staff and consider adrenaline infusion, 0.05 to 0.5 microgram/kg/min. Continue giving IM adrenaline every 5 minutes until 4 access is obtained. Other treatments to consider. Repeated doses of IM adrenaline together with nebulized or MDI salbutamol is recommended if the child has respiratory distress with wheezing. Also consider other anti-asthma medications. Antihistamines may be given for symptomatic relief of pruritus. Second-generation antihistamines are preferred, e.g. ketorolac. Avoid promethazine as it can cause hypotension. Corticosteroids and leukotriene antagonists have no proven benefit in anaphylaxis. Avoid NSAIDs. Observation and admission. All children with anaphylaxis should be observed for at least 4 hours. In a supervised setting with facilities to manage deterioration. Admission for a minimum 12-hour period of observation is recommended if further treatment is required within 4 hours of last adrenaline administration, biphasic or prolonged reaction. Previous history of biphasic reaction. Poorly controlled asthma. The child lives in an isolated location with delay to emergency services. Anaphylaxis to monoclonal antibody. The acute care setting should provide resources, education, and follow-up options to the family, including update the medical record, highlighting suspected allergen to avoid, and health department notification if applicable. See additional notes below. Blank. 2 EpiPens /EpiPens JNR /Anapens, and training in correct use with an EpiPen /Anapen trainer. Current dose. Recommendations are 7.5 to 20 kilograms equals EpiPen JNR, or Anapen, 150 microgram, and GT 20 kg equals EpiPen, or Anapen, 300 microgram, and GT 50 kg equals EpiPen, or Anapen, 300/500 microgram. Blank. Blank. Consider provision of a blank. Print parent and patient information sheets from blank. 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 For fatal and asthma control. Ensure that asthma control is addressed, including diagnosis, action plan, and preventers, as asthma is an independent risk factor. For fatal anaphylaxis, see blank. Peripheral for adrenaline infusion. This should only be done in consultation with a senior staff member. Avoid high infusion rates for more than 2 hours as it may cause fluid overload. Check local health service adrenaline infusion guidelines. Below is an example guideline. Mix 1 ml of 1:1000 adrenaline in 1000 ml of fluid. Suitable fluids are glucose 5%, glucose 10%, sodium chloride 0.9%, saline and glucose with sodium chloride combinations. Start infusion at 5 ml/kg/hr. This is equal to 0.1 microgram/kg/minute. A dedicated line, infusion pump and anti-reflux valves should be used when possible. Titrate dose according to response and side effects. Monitor continuously all vitals, 12-lead ECG, and conscious state. If possible, insert a second 4 as fluid boluses may be needed. Blank. Nebulized adrenaline is not recommended as first-line therapy, but may be a useful adjunct after IM adrenaline if upper airway obstruction or bronchospasm is present. If airway edema is not responding to parenteral, IM, 4, and nebulized adrenaline, early intubation is indicated. Consider consultation with local pediatric team when high risk of fatal anaphylaxis, more than 1 dose of adrenaline required. First diagnosis of anaphylaxis. Anaphylaxis to monoclonal antibody. Consider transfer when inadequate adrenaline response, multiple doses of adrenaline, adrenaline infusion, immediate life-threatening situation. A child requiring care beyond the comfort level of the hospital. NB. Also consider consultation with pediatric allergy/immunology team. Consider discharge when. See observation and admission section above.